Hello, I'm Dr. Steve Miles. I am a interventional neuroradiologist practicing in Daytona Beach, and I have been the Chief Quality Officer at my hospital now for about a year and a half. And in that job as Chief Quality Officer, I have learned a lot. And one of the biggest things that I have learned is the problem that we all have, and it's a we all have, with central line associated bloodstream infections. When you look at the problem, that problem is universal in hospitals, and that problem is a problem of safety, because none of us want a patient to come to a hospital and end up in worse shape than they arrived in. I'm going to talk slow and carefully because I believe we do still have a small lag in what you can see, hear, and what I can say. The problem is visible because it has significant increased cost. And the cost between cases runs between $20,000 and $30,000 of added cost. The most recent study that was well documented in the literature ascribed a cost of $26,839 to each central line associated bloodstream infection. Centers for Medicare Services, CMS, has a large body of literature out there that says that these types of conditions add approximately 43% of additional cost to total care. Because this has such high visibility, that CMS started asking hospitals to report central line associated bloodstream infections, or CLASPs. They started the reporting process by allowing a 2% increase in Medicare payments to hospitals that would report this data in an abstracted fashion. What that means is that they would pay hospitals to have chart auditors go through charts and document and report central line associated bloodstream infections. Once they got their mind around the process, they started in 2013 with a Medicare process called Pay for Performance. And what this did was, starting in 2013, they would actually reduce payments to hospitals based on the central line associated infections. Their goal is to decrease these infections by 50%. So therefore, this problem has very high visibility, not only from the patient, but from the lay press, but from the C-suite hospital administration, because there's real monies associated with this problem. Starting in 2015, infections related to hospital care get reported on the physiciancompare.gov portion of the Medicare Hospital Compare website. The best thing that CMS did was moved us to a clearly defined definition of what a CLABSI is. It is defined as a primary bloodstream infection in a patient who has had a central line infection within a 48-hour period before the development of this infection. And their infection is not related to another infection at a different site. What they're saying is if you put a central line in a patient who doesn't have an infection, he develops a positive blood culture within a 48-hour period of placing that central line, that is counted as a central line associated bloodstream infection by CMS. There are clear requirements for reporting these bloodstream infections. And I have put these together in a couple PowerPoint slides. You don't have to save them because I've got a reference at the end where you can just download this information. And as you can see, it's a 3-step process to document the presence or absence of these findings. This requires a lot of thought in the abstraction and the presentation of this data. In the surveillance data where they asked us to start reporting these, it took them about a year to get their collective minds around what they were going to call an infection. And in a nutshell, that line infection has to be in place for longer than 2 days. It has to be a laboratory confirmed bloodstream infection. And the date that the line was put in is the most important part of this documentation process. Now, if you go back and look in your hospital with an electronic health record, probably 2/3 to 3/4 of the central lines put in your hospital are not put in a recordable event that can be abstracted in an electronic medical record. That becomes key because if you're going to get your hands around this process, what you can't do is start looking through chart after chart after chart for a progress note to see where and who and why a central line was put in. Our first simple recommendation would be that there has to be a taggable electronic event, such as an order placed in your EMR, that allows you to see who put the central line in, when it was put in, which is key, time and date, and by whom. The last thing you have to pay attention to is that patients are transferred in and out of facilities with central lines. And there actually is a transfer rule that's very well spelled out. It says, in a nutshell, that if all elements of the central line associated bloodstream infection were present within 2 calendar days of transfer, one location to another, CLABSI is attributed to the transferring location. So it becomes very important that when you accept transfers from other facilities who do have central lines in them, that you do document that line was present on admission. And you need to look very carefully to make sure that if the patient comes down with a central line associated bloodstream infection the day after transfer, that you are not tagged with that event. The other key to the whole process is a central line infection cannot be attributed to non-bedded locations, i.e. the operating room or the emergency department. So if you're tracking central lines, you have infections, you have to know who put the ones in and where they were put in. If their lines are being put in the emergency room, the patient's transferred to, say, the 5th floor, develops a central line infection, that infection gets tagged to that floor. Same thing with central lines put in the operating room. And so now when you look at it, you know we have a problem with central line infections, that we know that they are easily identifiable. We know that there are clear definitions of how you identify them. There are clear definitions of who owns them. What I'm doing, just to stop the lag, I'm opening up the rest of the presentation. We can talk through this process. There are institutions who have line-related infections that really approach zero. And when I look at my organization, we put in over 1,500 central lines a year on a slow year. And you have institutions who are putting in 5,000 to 6,000 central lines. They will literally go 18 months without a central line infection. And the question is, how do they do that? It actually is very simple. The first thing that everybody has discovered when you look at central line associated infections, that having a dedicated insertion team is about a third of the battle. You clearly have to have individuals who put in central lines on a regular basis, who understand sterile procedure, who understand patient and doctor protection, gowns, gloves, masks. But everybody discovered very quickly that the other 2/3 of the process is a dedicated care team that rounds on and manages a central line. Because a central line becomes, I always call them now, something in addition to the patient care. It's just something that they have and something that nobody owns. And we've all seen patients moved around the hospital who have central lines in on the left side, the ET tube draped on the left side. It's wet from secretions, laying on top of a central line without a line barrier over top of it. That central line is a setup for infection. It's a direct portal to the bloodstream. Most of the line infections are attributed to poor care of the line. And when you have a dedicated care team managing these central lines, somebody knows who put it in, somebody knew how long ago it was put it in, somebody manages the dressing changes. And the best thing that somebody does is figure out why the line is still in the patient. Because a central line is a great patient care convenience for nurses and doctors. But the best way to not have a central line infection is not have a central line. This dedicated care team responsibility starts with putting together the guidelines or so-called care bundles that allow you to not only put a line in safely and aseptically, but care for them. And these care bundles are the key to everybody's success with central lines. And IHI has been a vigorous component of care bundles, and they've distilled it down to really 5 things that are important. And everybody who deals with and puts in a central line has to understand the importance of hand hygiene and aseptic technique, not only in placing the line, but in using the line and managing the line. Everybody has to understand about maximal barrier precautions, i.e. when you put the line in using very sterile technique with enough help where you have a free hand to make sure that we're not inadvertently contaminating the site or the line. And then when the line is inserted aseptically, a barrier goes over the puncture site that doesn't allow this to be contaminated. There is a lot of literature out there on using chlorhexidine skin antisepsis instead of betadine. Chlorhexidine is actually easier to use. Literature does say, although there's some debate, that it works better. I use chlorhexidine, and I use it because it is easier to apply, and it comes in, I think, much better dispensers. The little chlorhexidine, the dispensers that come in the central line kits actually have enough chlorhexidine in them. The betadine swabs that come in those line kits are invariably either dried out or don't have enough betadine in them. The fourth thing that everybody has discovered is very important is optimal catheter site selection. Everybody knows and should know that you avoid the femoral lines at all costs. The groin is invariably the dirtiest place. It's the hardest to clean. It's the most difficult to manage. IJ lines are the easiest to put in, but what happens, especially in males usually become colonized very early by staph in the skin because of shaving every day. And there is a lot of literature out there that talks about putting central lines in IJ as a safer, technically a safer place to put a line, but a higher risk of infection. The most important thing is just a daily review of, is this line necessary for the care of this patient? And if not, let's remove it. And again, I'll have you, there's a IHI website. You can download these care bundles from that I have made available at the end of this presentation. The Society of Interventional Radiology has been very active in putting together care paths and care bundles, and there actually is a strongly worded recommendation document put out by the SIR that's on their website. And they did actually a very good job of breaking the recommendations down in categories. The first category, 1A, is strongly recommended and is supported by best practices. A 1B guideline is recommended, but the rationale, the best practice, or the studies proving the best practice is not as clean cut. 1C is a recommendation by the state or federal guidelines, rules, or standards. 2 is things that we all know are probably true. We just don't have and probably won't ever put the study together to prove it. And then there's a whole series of unresolved issues, which there is not enough evidence to make a recommendation one way or the other. And if you look at the recommendations for education, clearly having the knowledge and the skill set to place and maintain central lines is supported by strong clinical evidence and best practices. Having competency for these individuals who not only place but manage these catheters is strongly supported by good clinical evidence. Not providing antimicrobial prophylaxis prior to a line is not supported by evidence. That is a hearsay that along the big clinical studies looked at that, and the consensus was that routinely administering antibiotics prior to a line placement doesn't prevent or decrease the amount of central venous catheter infections. And also the continued use of anticoagulant, i.e. flushing these lines or constantly dripping lines in these, even though you would think it would help, doesn't routinely reduce the amount of infections in these lines. There is a good recommendation for catheter site. The recommendation to use a PICC line or a midline instead of a central venous catheter if it's going to stay in there for longer than 6 days is a good suggestion because they're easier to care for, with less risk of infection, although they are not as user-friendly. We all know that using a fistula or a graft in a patient rather than a central line for dialysis is better. The less ports, the better. A double lumen or a single lumen is better for infection rates than a triple lumen because the more ports you have, the higher the risk of infection. Again, you see prompt removal of the catheter. Again, you can't have a central venous catheter infection if you don't have a central line. The use of the subclavian site rather than the jugular or femoral site, again, has been worked out actually very well because of, mainly in males, the issue of skin asepsis in the face. They recommend chlorhexidine or silver sulfidine catheters in patients who are going to have a line in for longer than 5 days. And if you put these strategies in place, you don't see your central line associated bloodstream infections decreasing, then you need to step back and reevaluate who is doing these and how you're doing these. And clearly you have to re-educate those who insert and maintain catheters. You should move to chlorhexidine rather than betadine because the literature bears out that chlorhexidine actually is a better skin antisepsis than betadine. And the last thing you need to do is really jump on what everybody calls MSB, or maximum sterile barrier precautions. And that is the cap, the gown, the gloves, the shoes, the body drape, etc. Because if you can't get your arms around the problem, then you have to start treating the insertion like a full-blown operation. Every time that you handle that catheter or change that dressing, you need to use sterile gloves, correct aseptic technique. They also recommend that if central lines are put in a crash or a code situation or a trauma, that you look at that line very carefully, and if there is consideration that the line was not put in with the best sterile technique, you should replace that in 48 hours. Now, nobody is advocating that I have seen the routine replacement of central venous catheters in put in those situations. My hospital, we instituted a program where all the central lines put in on the field would be replaced within 24 hours. And we found that that did not make any difference in the amount of central line infections we had. I think that is true because it boils down to most of the problems are associated with the care of the line and not the insertion of the line. When you look at the education, there is a lot of information out there on training the individuals to put lines in and train individuals to manage the line correctly. And people who have pushed the number near to zero have strict adherence to what they call line bundles or insertion bundles. They make it very easy that if you're going to put in a central line, everything that an individual needs is either in a package or on a so-called line cart. So nobody has to go around and look for the sterile drape. Nobody has to go around and look for the mask or the shoe covers or the hair cover. It's all right there. And if it's all right in front of you, it becomes easy to use. It also has to be ownership from nursing that when these central lines are put in, that everybody is paying attention to the insertion bundle, that we are using the maximum barrier protection. We are prepping and draping the person correctly. That we are waiting for betadine to dry, that we're not just into what I used to call the slash and stab mode, splash a little betadine on, put the line in and move on. And when you look at central lines as a process, we know it has high visibility, has real money associated with the problem. There's clearly an identified patient safety issue. Coming from a background of interventional radiology, where I've had nurses available with me for the last 18 years, I guess the first 2 years of my practice, interventional nurses didn't exist. I got my first nurse in 1991. I realized that there is one very competent group in the hospital who understands lines, wires, catheters, sterile dressings. And that is the interventional radiology nurse. And when you look at problems who've had successful line teams, they usually come out of interventional radiology. Those line teams end up with a core group of individuals who are dedicated to the central line infection issue. They own it. They use evidence-based practices, and they hold themselves accountable for those. And it's actually pretty easy to put together one of these teams because all you need is a nurse who wants to lead the charge. It's actually very easy to get an administrative or a C-suite sponsor, because if anybody walked up and asked somebody on the CFO side of the hospital what the cost of a central line infection is, it's usually at the tip of their tongue. It's very easy to find a physician sponsor, physician champion, because the vascular radiologist, interventional radiologist, actually are usually very involved in this process. And you can use that physician as a physician champion. Use your interface, or he or she is your interface between infection control, the lab, who document and monitor these, a quality department who reports these, materials management who actually goes out and evaluates and purchases the central line and or central line kits that you use. You have to have buy-in from the chief nursing officer. because the care of the line is a nursing issue. And we all know that people can be very territorial with nursing issues. However, I have found in my little short career in this job that anything that is a potential problem, people are very easily absolve themselves of that responsibility of a potential problem by passing it on. And I really think that the IR nurses should own this process. You have the best skill set of nurses in the hospital for this. IR nurses are very good with sterile technique. They have good insertion skills. They understand usually the first assist or primary about PICC lines and central lines. They also have a very strong physician backup because most interventional programs, there are only a few interventional radiologists with a half a dozen or more interventional nurses. And it's a good way for both the physician and the IR team to have high visibility. Because if you start rounding on these patients, you're very visible throughout the hospital. I know in my facility, towards the end of the day, we all go up and round on the IR patients. We do what's called take the abscess book. We all pull up the tube and line book and look and see who's got lines, who has tubes, and go up and evaluate those patients and check on them. And if you include rounding on patients who have central lines in your process, you're probably going to find out that most of the patients who have central lines have or will be IR patients anyway. And I'd like to make a strong argument that this process should be owned by the interventional radiology nurses. And again, I think you have the best skill set for that. I also think that you have an easy way to round on these patients because they're already in your skill set to begin with. If you wanted to snippet or screen capture anything off the screen, this is a list of the websites that have everything that you need for putting together a line team and managing a line team. And none of this in these websites is going to be news to anybody, but it does clearly spell out what the problem is and how to go about solving it. And you solve it with a dedicated line team. You pay attention not only to the insertion, but to the care of these lines. And I think it's a very easy process to get into. It has high visibility in the hospital. Immediately elevates the interventional lab, which is usually in the small corner of the hospital, stuck so far down the bottom nobody knows where it exists, to the front of the C-suite, because the hospital-acquired conditions, or HACs, as they're called, are going to be the single largest expense item for a hospital. Materials management used to be the largest expense item to a hospital after FTEs. But when we're all held accountable for these hospital-acquired conditions with payment reductions, cost avoidance or reduction avoidance becomes a solid business plan. Again, that is the end of my discussion. I do know that we can actually audio or video chat on this program. I think on your screens you can actually raise your hand and submit some questions if you like, and I'd be happy to try to answer them for you. Questions?
Hello, Dr. Miles.
Hello.
Dr. Miles, can you hear me?
Yes.
Hi, Dr. Miles. I'm sorry. Sometimes the audio gives us a little bit of a hard time. I'm Karen Marshall, and I do want to thank you very much for being so gracious in your time today.
Like I say, Ed and I also struggle, but I think we got it going.
I know. You know, I was sort of had heard from Ed that you had a really nice format, which maybe we'll look into try ourselves, as sometimes we have audio issues, as you can hear. But I do appreciate you working so hard and working with him. There are some questions on the format. One of the questions is that part of your team, you did such a great job in describing the importance of a team involvement with your PICC lines. And, you know, we often, many facilities have that sort of support, and as you mentioned, many facilities don't, and you certainly encourage it. Some of the concerns are, though, with ID. It's sort of a two-part question. One is, you know, is infectious disease part of your team? And when you have a patient who has a very active infection and they need to have a PICC line, how does that really affect the actual management of the PICC if they've already got something underlying that's pretty serious?
What happens is, and you probably have the same class of patients that we have, patients who come in IV drug abusers with endocarditis or whatever that need high-dose antibiotics. And we invariably put PICC lines in those patients for short-term use. And we know we're putting a line in an infected patient. We document that very carefully. The bigger problem we have with those patients, the IV drug abusers, is trying to keep them from using a central line in the hospital as a portal for intravenous drugs when their family and friends come in visits. Using infection control or ID, they have become our best friend because they are actually very helpful in attributing the central line, the infection to the line and not to the underlying abscess or pathology the patient has. I said early on, documenting the line infection and attributing to the central line is actually boiled down to rocket science, but it does take somebody who understands the lab values, the time the line was in, and other positive or negative cultures that were around that. So they are an integral part of it, and they welcome help because most of them fall away in silence.
I see. That's really great. I'm looking just to make sure if there are any other questions. I don't see any other questions at this time. Dr. Miles, would we have permission from you to be able to perhaps even share your email or maybe your administrative person's email should an audience member in the future have a question? As you know, we record these webinars.
Yeah. My email address is up there, right?
Let me see. Well, we will certainly make sure that everybody has it because when we record this, people view it in the future as well. And we'll just make sure that everybody has it. We do appreciate that. I do have one announcement. Ed has it. Okay.
Ed has my email.
I do.
Sent it to him.
Okay, that's perfect. I appreciate that. So everybody who was participating today will receive an email either today or tomorrow. In that email, there will be a way to evaluate the webinar. We also share those evaluations with Dr. Miles, so he is able to obtain some feedback from today. And once that, yes, that's very helpful, I think. And once the evaluation is completed, it'll sort of prompt for the certificate for you to be able to print it at home as well. So if there are no other questions, we will let Dr. Miles get back to his busy day. And we really appreciate your time. Thank you so much, Dr. Miles.
You're more than welcome. Thank you. Bye.
Thank you. Have a great day.
Yes.
Bye-bye.